So good evening. Well, I will be speaking on the different types of ear surgery, just to give a glimpse of how the surgery has been done. I will try to cover almost all types of indication. Um, we are not covering the buccal part as that it's been already been dealt. So to start with, we'll start with the macular cases. This is a case of an epiretinal membrane. As you can see, the vitreous being stained with the transilon acetate. And once we clear and the PVD has been induced, you can see with the forceps, we are actually picking up the epiretinal membrane. This was quite a thick membrane, so we could clearly see the membrane and just picked it up. And then did a fluid air exchange. This is the case of a macular hole. You can see after doing the PVD, we have stained the ILM with the BBG dye. You can see from the contrast, the staining is quite good. And then with the pinch and pill technique, we are taking off the ILM and trying to move across the macular hole and try to enlarge the area of ILM peeling. I always try to make it arcade to arcade. The third case, this is a macular hole along with epiretinal membrane. As there is a epiretinal membrane, the staining is not very good. So you can see the nasal part is stained. So we are taking the ILM and trying to find the edge of the epiretinal membrane. That's the epiretinal membrane. We are taking it off. And once we take off the epiretinal membrane, now we can stain better with the BVG. The ILM, you can see the remnants of the ILM. And then do the ILM peeling. Most of the epiretinal membrane cases also, we follow this method. We peel the ILM as well. Obviously, in the macular hole, we have to do it. So we are extending the ILM peeling till the arcades, from arcade to arcade. And before that, we have already removed the epiretinal membrane. This is the case of a large macular hole. Nowadays, what we do is a different technique of ILM peel. Instead of peeling the ILM in toto, we keep the ILM at the edge of the macular hole. As you can see, we are picking it up and keeping at the edge of the macular hole so that we can dump the ILM inside the macular hole, which can form the scaffold and the macular hole can be closed. So while doing it, in this case, you can see a part of the free edge has come off, and so the ILM is not falling just over the macular hole. So we did little bit of improvisation in this case. After peeling the ILM from arcade to arcade, we did a fluid air exchange, and then we put some visco droplets and manipulated the ILM over the macular hole so that it doesn't dislodge it. This is a case of a retinal detachment and a small pupil. Small pupil is always difficult, whether it's cataract or a retinal detachment. So you can see with after putting the iris hooks, we can do this detachment. We can get a good amount of film. We are draining the subretinal fluid from a retinotomy, which is done nasally. And once we are through with the subretinal fluid, then the retina is attached and we are doing the laser, the retinoplexiplot. As this was a pseudophakic and there was some lesions at the periphery, multiple lesions at the periphery, we did a 360-degree laser. This is the case of a comparatively older detachment with a choroidal detachment along with the retinal detachment. You can see the thick fluid is coming when we are doing the vitrectomy near the break. And then after doing a proper base dissection, you can see at the bit, this part, the choroid, it's still there. But it was not that massive that we need to drain it. It could be managed without drainage. And once we have done a meticulous vitrectomy, we are doing a fluid air exchange. As you can see, the break is quite big enough. So we are not doing any retinotomy in this case. We can easily drain the subretinal fluid with the existing break. Now the retina is settling down. Once it has fully settled, then we are doing the laser. In this case also, this was an old one with the multiple breaks, multiple lattice in the periphery. So we are doing a 360-degree laser. So once we have done the laser retinoplexy, this is a lattice. We are giving the tamponade in the form of silicon oil. In this case, you can see the choroidal detachment is quite a massive one. So we cannot approach this patient. The field of view will be difficult. So we are draining the choroidal detachment before approaching the retinal detachment. So this is one of the methods by which we can drain the choroidal fluid. You can see we are draining the choroidal fluid. Once we drain, you can see the choroidal detachment which was visible, we can't see, so it has subsided, and then we can approach the retinal detachment as we can plan, because now the field of view is quite good. And once we drain the subretinal fluid, we are doing the laser, and following that we will give the silicon oil. This is a case of a diabetic TRD. These cases we need to be very careful. These are the dissection part, the membrane. We need to find out the plane of the membrane and dissect the entire membrane. The retina is detached, so we need to be very careful, and so that there is no iatrogenic break. Another part we need to take care is the bleeders. We have to take care of the bleeders by diatherming cauterizing the bleeders, because this cases many a times re-bleed later on. So we have to take care of the bleeders. And then there was a little bit of subretinal fluid. We drained it, and then we have to do a very good laser. As you can see, there was no previous laser been done. That is the reason the case was a little bit florid. This is another diabetic cases, but here the fibrovascular proliferation was not that extensive. You can see there's a non-resolving vitreous hemorrhage, but here we need to take care that not inducing the PVD blindly, because sometimes the membranes are attached and you might create a iatrogenic break. So this is the membrane. We have dissected out we have taken out the vitreous hemorrhage, and then we can actually clearly see, we can see the anatomy clearly, and so we can actually dissect the membrane without injuring the underlying retina. This was a small membrane we picked up with the forceps itself. So once we have cleared the membrane and the hemorrhage and a meticulous vitrectomy, we have to do a good laser to prevent the rebleeding. This is one of the case of nucleus drop. You can see the entire nucleus is on the retina. So what we have to do before dealing with the nucleus, we have to do a good vitrectomy, because the entire nucleus is there. So I will be using a fragmentome. As you can see, we are using a fragmentome to deal with the drop nucleus. You can see we are doing a phaco in the mid-vitreous. And gradually the entire nucleus we have eaten up. And once we have done so, we have to put some triamcinolone, and we have to ensure that the PVD is induced and there is no residual vitreous as such. This is similar. Instead of nucleus, this is an IOL drop. So we have done the section. Before that we have done the vitrectomy, and now just doing a little bit of vitrectomy around the IOL. And once we have done it, we're opening up the main wound and then getting hold of the IOL and prolapsing through the anterior chamber, limbal route. And then we are doing a base dissection, and this is putting in secondary IOL. This is the lens we generally use. This is an iris claw lens. You have to just push the iris in between the flanks of the iris claw. One side is over, we'll deal with the other side. Just change your hands and with the spatula or the Sensky hook, push the iris into the iris claw. And this is the last case. This is a chronic endophthalmitis. As you can see, the yellow exudates, which almost resulted in occlusio pupillae. In this case, you have to take out the IOL, otherwise you cannot proceed much. You will it will be very difficult to visualize. So once uh, we deal with such kind of cases, we have to take the IOL. Now we have taken out the IOL. Now we have to suture it, and then in a closed globe, we are actually dealing with the exudate. You can see the very thick exudates. And here you have to patiently, very carefully remove as much as exudate as possible. You can see we are actually, the visibility is quite good. So we could actually deal with the membranes which is sitting that just over the retina. In fact, this patient did pretty well. After 3 months, we got put as secondary IOL. So this is all about the different types of the VS surgery through the MIVS system. And with the better instrumentation and obviously the viewing system, we can definitely give a predictable outcome. Thank you.